Thank you for joining us for our free CE to members. I'm Paul Roberts. I'm the Outreach Director here at the MDA. And the neat thing about tonight is we're recording this presentation that will be available on MDA's new digital platform called Mo Dental on Demand. That way, if you have a conflict tonight, like over 100 of the people who have registered, you can go on the site during your own time. You can watch it and you can still get CE. And you can also watch part one if you missed it and get CE credit for it. So go tell a colleague to watch it. Maybe you want to revisit it and review your notes. It's all designed to be a member benefit. And I want to screen share just a minute to show you what that looks like. So this is Mo Dental on Demand when you get there. Right now we're under membership and member features, but you see right here, Pediatric Pearls Part 1. There's a brief sign in with your email. You can watch through the video. There's a link at the end. You can get your CE card. You can pause and do all those good things. And certainly by early next week, we'll post Part 2, and they'll both be on there as well. Okay, so let me see here. Nope. Where's my stop share? There it is. Okay. All righty. If you like tonight's format and think you might want to be a contributor sharing content beneficial to our members, just reach out to me and we can discuss ideas for a time to do that. I'd like you all to stay muted. If you have a question during the presentation, put it in the chat. Dr. Popejoy is going to pause several times at the end of each kind of chapter and answer any questions that are in there. And then if there are any resource links that she references during the presentation, she'll email those to me and I'll include that in the email tomorrow that I send you with your CE card. So right now, let's get on to the good stuff. Part 2 of our Pearls of Pediatric Dentistry. Our speaker is Springfield pediatric dentist, Dr. Ashley Popejoy, and she's the clinical director of oral health at the Jordan Valley Community Health System. Ashley, you can unmute and I'll make it so you can share your screen. Welcome.
All right, perfect. Thanks, Paul. Okay, let me get this open for you guys. So I really appreciate everybody who has made it a point to come out today. I do hear that you guys have great weather. I'm actually in Florida right now, so I'm sharing that good weather. But thank you for joining. Like Paul said, we had a part 1 back in January, and so this is just really going to complement that. It can stand alone. But it also could be something that you could watch in tandem. And so if you feel like you're missing out on some information, and I'll reference some things that we talked about last time, just make sure you go to Missouri Dental on Demand, and we can have both of those available to you. So tonight we're going to talk about clinical techniques for restoration of the primary dentition. And specifically, the things that we are going to be talking about include non-invasive restorative techniques, also preparation of traditional stainless steel crowns, anterior full coverage restorations, including traditional new smiles as well as zirconia crowns. We are also going to talk about pulpal therapy for primary dentition and immature permanent molars and space maintenance. All right. So non-invasive restorative techniques, we use these quite a bit in pediatric dentistry on uncooperative patients, very young patients, or patients that we just need to postpone invasive treatment, or we're trying to postpone advanced behavior management. So I do have a lot of patients where maybe the kiddo is extremely young and the parents want to avoid general anesthesia. We just need to wait some time before we are to the point where we want to use those more advanced behavior management techniques. Or maybe, they've been sick recently and aren't healthy enough to undergo general anesthesia at that time. And so we need to postpone it for a while. Options that we're going to talk about today include silver fluoride, which we talked about in part 1 of our series. So make sure to take a look at that. We're going to talk about Hall crowns today, as well as interim therapeutic restorations. And the benefits really are that you can avoid local anesthetic frequently. You'll have shorter appointment times, and you can have limited use of the handpiece instruments. So that can be really important in these really young kids that were trying to overcome some behavior or really get through a limited treatment plan where we want to avoid some of those advanced behavior management techniques. So Hall crown technique, I actually use this quite a bit. I get a lot of referrals in our office, and sometimes the referrals are for just 1 or 2 teeth or even 4 teeth. And we look and we notice that, we might not be to the point where we really want to consider general anesthesia as an option yet, just because of the limited treatment plan. So the number one thing is that you really have to have proper selection of the teeth that you're going to restore with Hall crown technique. You want it to be symptomless. You want to have no clinical or radiographic signs of pulpal pathology. And what that means is that you have to have an x-ray, right? So I will not do a Hall crown on a tooth that I can't get an x-ray of because of behavior. So if I can't get an x-ray, we're talking about different options. But Hall crowns generally are used for posterior primary teeth. And what the option is here is to be able to place the stainless steel crown without having to numb and without having to utilize the handpiece. There are times when you can use orthodontic separators to help open the space between 2 teeth to place these Hall crowns, but not always. So the method is going to be that regardless of whether you use separators to begin with at a previous appointment or not, you'll sit the child upright in the chair. This just reduces the risk of aspiration as opposed to leaning them all the way back, and then use a throat pack. You will want to assess the size. The way that I do this is I look for a size of a crown that looks like it's going to fit over both buccal and lingually, and then I push it down slightly until I can feel some spring back. But you don't want to push it all the way through the contact points because getting it off again will be a challenge. And so you just really want to get good at being able to kind of see whether a crown is going to fit or not. When you use separators, if you decide to use separators, I like using the 2 pieces of floss method. So you grab the orthodontic separator, you take 2 pieces of floss and thread them through the separator and pull it taut, and then just slide the separator through the contact. You'll have 1/2 of the separator underneath the contact and 1 at the occlusal plane. And then that will allow there to be some separation. Usually those are placed for about 2 weeks, and then the child comes back. A lot of times the separators have fallen out, and that's okay. And then you place the Hall crown at that second appointment. However, very rarely use separators. I usually will do my Hall crowns on the same day as the consultation. And it just requires a little bit more pushing. Sometimes the kids don't love the feel of the tightness, but they also don't love the feel of the tightness of the separators. So it's kind of just determining what's going to be best for that patient and that family. Once you've picked out a size, your assistant will fill the crown with a GI cement. Usually I use Fuji 1, but you could also use Key Tack. And then you place the crown over the tooth. I usually go ahead and push with thumb pressure my own crowns on and then have the child bite on a bite stick. You could also just have the child, if you have a really good behavior, bite on the bite stick to seat it all the way. And then you'll remove the excess cement. There might be some hyperocclusion, but research indicates that hyperocclusion and that open bite will resolve in about a month after placement. And I have not had any kids back with postoperative sensitivity following these Hall crown placements. So really good, really non-invasive technique that you can utilize for kids who are not quite ready to sit in the chair for an entire traditional restorative appointment. I will use these for small interproximal lesions. I'll also use them for big interproximal lesions as long as the caries isn't clearly into the pulp. Once you have any symptoms, specifically spontaneous symptoms or any evidence of pulpal pathology in your radiographs, this is no longer an option. Another option that we sometimes use is interim therapeutic restorations. And so this is, just what you think of when you've got a kiddo that isn't going to be able to tolerate treatment and you want to do maybe just a resin restoration. Maybe it's one of those kids that has a new 6-year-old molar and they need a buckle, but they're not going to be able to sit still for numbing and then utilizing the handpiece, or they're just too anxious for those kind of more definitive restorations. This is what I'll use. In this process, you're going to remove the bulk decay using slow speed or hand instrumentation, and then restoring with a glass ionomer or RMGI material. I will usually either use Fuji 2 for my light cure or Equia Forte, which is dual cure when you use it with the Forte coat. I like these materials because they're favorable. They have favorable properties, specifically chemical bonding to both enamel and dentin and to itself. The thermal expansion is similar to that of tooth structure. It's very biocompatible and it uptakes and releases fluoride. And so usually you're going to see hopefully a little bit less recurrent decay with these types of restorations, at least on an interim basis. They also have decreased moisture sensitivity. So if you've got a kiddo that can't tolerate the dry shield or barely is tolerating putting a cotton roll by the tongue, this is a good option for you. So those are really the options that I give parents when we're trying to kind of get through things at a younger age or maybe a pre-cooperative stage. In a future slide, we will also talk about knee to knee strip crowns, where I can do strip crowns on anterior decay for our really young population, like our 1, 2, and 3-year-olds that can sit knee to knee with their parent. But for now, those are kind of the major topics in kind of non-invasive or minimally invasive dentistry. So, Paul, are there any questions in the chat about those specific topics?
Not right now.
All right, now, okay. Well, great. If y'all think of any, just put them in the chat. But for now, we're going to move on to some more traditional restorative techniques. Specifically, now we will talk a little bit about the traditional prepping of stainless steel crowns. So I think that stainless steel crowns get a bad rap sometimes, but they are an incredible treatment option for patients who are really young, patients with a really high caries risk. So those kids that you see that have 8 interproximal lesions on their posteriors, this is a great option. It's also great for hypoplastic teeth, for that ability to have full coverage and help with that sensitivity. I utilize it for class 2 lesions that are beyond the anatomical line angles. And I definitely utilize it if I have any pulp treatment that I'm going to be doing, even indirect pulp caps. I prefer a full coverage restoration. And from an evidence-based perspective, these restorations are more successful utilizing a full coverage restoration. It's also great for patients with special needs or with hereditary anomalies. A lot of times we will get referrals of patients with amelogenesis imperfecta or dentinogenesis imperfecta, and the guidelines really go into restoring those posterior primary teeth and anterior primary teeth with full coverage restorations. And so this is what we end up doing. For the stainless steel crown preparation, really the big things that can really make these harder on you and on your patient is just a couple of simple tips. So the first thing is that the prep is subgingival, especially on the interproximal areas. You really want to get into that subgingival area so that you get a good snap and so that you don't get a ledge on the mesial and distal of your crown. And then the other kind of big tip is just making sure that they're seated when you've got back-to-back crowns, that they're seated with the marginal ridges even with each other. Those are kind of the mistakes that I'll see people who haven't done a ton of stainless steel crowns make initially. So for the preparation, you are going to do about 1 to 2 millimeters occlusal reduction, obviously more if you're going to end up doing a pulpotomy. You'll do subgingival interproximal reduction with complete clearance. So you really want that explorer to be able to just glide through those interproximal areas. I also make sure that I clear the distals of my second molars as well. And this is because if you don't, you can get some impaction of your permanent first molars underneath the ledge of that crown. There's some ways to kind of get around that, but I always do prep the distals of those second molars, and it'll help you fit a smaller crown as well, which will help with retention of those crowns long term. Reduction of the buccal and lingual is only necessary if the supplemental anatomy requires. So these crowns are made to be seated with a lot of mechanical retention from that buccal bulge, especially on those primary first and second molars. And so you don't necessarily want to do a lot of reduction on the buccal and lingual. Sometimes if the primary first especially has a really large buccal bulge, or the primary second has like a cusp of Carabelli or something of that nature, then I'll do some lingual or buccal reduction. But for the most part, you want to keep it, because that's what's going to keep your crown on way more so than the cement that you're using. Trial placement of the stainless steel crown first, and then use your throat pack to take them off again, because they do tend to slip and fly. You'll also want to contour and crimp if necessary. I always do crimp the distals of my second molars for the same reason that I do an interproximal slice at the distals of my seconds, so I can have that nice form fitting on the distal and not cause impaction of the permanent first molars. And then you'll do cementation. Again, I tend to use Fuji 1, but there's lots of other glass ionomer cements out there that you can use, notably Key Tech, if that's what you like. And then removal of the excess cement. It does end up, after you've done quite a few, it does end up being a relatively fast procedure, and something that you can incorporate into your practice that hopefully will be a really long lasting thing for kids. And then they can move on with their permanent molars later, after these teeth exfoliate. You do want to select the smallest crown that restores the existing proximal contacts and provides full coverage of the prepared tooth. So the things you want to look for is making sure that those marginal ridges are even. If it looks canted, or if it looks like it is a different height than the tooth adjacent, then you know it's not seated all the way, and you should check for a ledge interproximally. In addition, if you do want to look at both the buccal and lingual and make sure that those entire surfaces are fully covered and that the crown covers them subgingivally, because you can end up with recurrent decay in those areas if it hasn't gotten complete coverage. The most commonly used primary molar size is a size 4. So that's a lot of times where people will start. Your assistants, as you do more and more of these, should be getting pretty good at picking out sizes ahead of time. Now in OR cases, my assistants can basically glance inside the mouth and tell you approximately what size all of the primary molars are going to be. But it will take some time with those specific assistants before they can get to that spot. I will also say that typically the primary first molars are one size larger than the primary second molars. So if you see an E4 on tooth number A, it's likely that tooth number B is going to be a D5. So that is somewhere to start at least. I always suggest using a throat pack. If your kiddo swallows or aspirates a crown, it does necessitate a chest x-ray to ensure that the crown has not been aspirated. And if it has, it becomes an emergency surgery. And so that throat pack becomes really important, or a dry shield, to prevent loss of these crowns, especially after you try it in initially. Getting it back off, if you've got a good fitting crown, is sometimes a little bit more difficult than you would hope it would be. And they can fly, and kids don't have that good reaction to be able to spit it out at you. Usually they're going to swallow, and hopefully they do swallow it, and hopefully it is in the stomach, but you still need to check. I always seat my crowns from the lingual to buccal. That is the way that they fit on the best. If you find, and I had a student on Tuesday in the OR that was trying to fit a crown, and if you find that it's kind of slipping to the lingual and you can't get it over the buccal, it just means that the crown is too small. So if you're finding that initially, you either need to do more prepping or move to a larger size crown. You will want to push the crown over the buckle bulge for a snap fit. It should kind of snap into place, and you'll use the bite stick to assure it's seated completely. And I think at least at UMKC, I almost don't want to say this, but 12 years ago, the peds department was always saying, you don't want any blanching, but from an evidence-based perspective, it's not harmful to them long term, and from a evidence of retaining the crown, it's usually necessary for there to be some blanching. In this picture, it's a little bit excessive compared to what I usually see, but you kind of get the point of how well fitting that crown is going to be and how subgingival it's going to be when it's seated correctly. And then I did just put in here, always make sure that you're contouring or crimping the distal surface of a second primary molar crown. And there's various crimpers that you can use. Really, it doesn't matter as long as you get that distal surface crimped a little bit so that you don't end up with a ledge that your permanent first molars can get trapped under. I do have a video kind of showing this process, and so I'll talk through it because I don't want you to have to listen to the dry shield and the sound of the handpiece, but this can just kind of show you what back-to-back stainless steel crown preparations look like. So obviously this kiddo was a young kid that was in our OR setting. So deep sedation, completely intubated. So, looks a little bit different. I'm not having to talk through the appointment with him, not having to do any behavior management. So that does help this go faster. But we're starting with a barrel burr. I like a barrel diamond, the green grit. And I do 1 to 2 millimeters of occlusal reduction, which is what I've done there. I typically will use another diamond for my interproximal strips. And so I'll use a green flame for that. But some people use 330s, some people use finishing burrs. It kind of just depends on what you're comfortable with. This is what I've always used. From an efficiency standpoint, I like utilizing the burr completely in the entire arch or quadrant before switching to a different burr. And so, trying to get all of your interproximals prepped before you're moving on to trying on, or typically in the OR, my process is going to be for an entire side of the mouth, I'll use the occlusal reduction burr. And then I'll switch to the interproximal burr, and then I'll switch to a 330 to do any pulps, and then I try on my crowns. So here, obviously we are having to do a distal slice there because the permanent first molar is in. And then my assistant has picked out sizes of crowns for me. And as I put them on, I have asked them for a different size, and so we'll retry on. And in this case, the first molar crown did not seat all the way on the buccal, and so they're going to give me a larger size. You do want to try them both on at the same time to make sure that you have adequate space for both. And then once you've made sure that those marginal ridges are even, you can plan for cementation. And so even in the OR, I'll use the bite stick. Of course, just be very careful with that bite stick if you're the one utilizing the pressure, because that biting surface can really tear up some soft tissue. The glass ionomer cements are generally not super moisture sensitive, but I do still try to get rid of the heme if I can. And then my assistant is filling up with glass ionomer cement. You see that there is some heme inside that crown, so it's not super moisture sensitive, but just kind of do your best to minimize bleeding. There's going to be some bleeding because you've gone subgingival, hopefully. And then for us, we are rinsing pretty heavily in the OR to get rid of excess cement. A lot of times kids won't tolerate that as much while they're awake. And so then you might have to do more of the manual utilizing of an explorer and floss to get rid of that excess cement. And that's the end of that one. Okay. I did put in here, and if you were available for our last conversation, we did talk a little bit about when to restore and when to monitor lesions. This is one of those situations. So this was a 10-year-old male who, what I'm really looking at here is this distal on number T. The factors that I'm thinking of and that we talked about last time were proximity to exfoliation, which in this case, this child has some premolars in, so we know that it's getting relatively close to time for number T to be lost. But also the other thing that I'm thinking of is that lesion is very close to the mesial surface of this permanent molar. And I kind of want to get that surface cleaned up in some way as soon as possible to prevent that mesial from starting number 30. In this case, that tooth was about to be lost. I think we actually ended up just extracting this tooth for them just to get that kind of lower that bacterial load for that mesial surface of number 30. But I could see, monitoring it to exfoliation as well, especially if they were improving on home care. In this case, we're looking at the distal of number B. Kind of a similar situation. You can see that some permanent premolars are starting to erupt. And so the decision is, do we need to do a DO resin on that tooth? Do we need to extract? Do we need to just monitor? In this case, I would have just monitored that lesion. Now, the mesial on number A, we probably, and we got a PA of that tooth, we probably would go ahead and restore. But monitoring that distal lesion of number B would have been sufficient. Okay. So the next topic that we have is treatment options for primary anterior teeth. So we've talked about posteriors mostly so far, but Paul, are there any questions that I can answer regarding what we've talked about so far?
Yes, there is. There's one question. When you're switching out the crowns or trying on different sizes, the unused crowns, do they get tossed or is it okay to sterilize and reuse?
You can re-sterilize them, and that is in the manufacturer's instructions. So you can re-sterilize those. I think generally they don't suggest that for primary anterior zirconia crowns, and so the anterior zirconia crowns they have try-on sizes that are pink. And so you can re-sterilize the try-on crowns, but not the actual crowns, because over time that any blood or heme that stays inside that crown can eventually turn it like a purpley color, which isn't super aesthetic. But the posteriors you can re-sterilize and use again.
All right, great. That seems to be the only question. So roll on.
Okay. Very good. Okay, so primary anterior teeth, obviously we have the ability to do direct resin restorations, but I wanted to make sure that I talked a little bit about some other options that maybe aren't considered as frequently. So the topics that we're going to talk about are active surveillance, interim therapeutic restorations with glass ionomer fillings, intracoronal restorations, composite strip crowns, pre-veneered stainless steel crowns, and zirconia crowns. We've talked a little bit about active surveillance already, kind of monitoring those teeth until exfoliation. We can do that quite a bit with anteriors, especially if you've got a family that's very motivated to change home habits. So when I see this is maybe a kiddo that breastfed on demand through the night for quite a while, but then has weaned and now is in a family where they're drinking lots of water, they're able to brush before bed and nothing to drink during bedtime other than water. and is coming in for frequent reevaluations, there are times that some of those facials are not super deep, and you can, or even interproximals are not super deep, and you can monitor them till exfoliation if that kiddo is about to lose those teeth. So, you know, one of the things that I notice is that sometimes we don't get anterior x-rays very frequently on young children. That we get the bite wings when we need to, but that a lot of the assistants are kind of skipping that anterior x-ray. And so I would encourage you to make sure that you are kind of looking for those x-rays and being able to assess interproximally before those lesions get really large, so that you can counsel parents on being able to change home care, that they know that they're there, that they can be flossing, drinking more water, that kind of thing. And so you can really explore the home care with the parents. If you don't know it's there, then you can't do that as easily. So that's kind of my tip on active surveillance. We talked about interim therapeutic restorations with glass ionomer fillings in the last portion, but I am going to talk a little bit about composite strip crowns and how we can do that in an interim therapeutic restoration way. And then we all know how to do class 3 and class 5 intracoronal restorations. But where I see a lot of questions that new pediatric dentists or new residents, general dentists who haven't treated a lot of kids or maybe are newer out of practice asking about are full coverage restorations like strip crowns, what we call new smiles, which are pre-veneered stainless steel crowns, or zirconia crowns. And so I am going to show a little bit of that. For active surveillance, I also kind of just wanted to put in here approximately what time period that those teeth are going to exfoliate. That being said, like we talked about at our last talk, this can vary quite a bit. I have kids that are 4 and losing ENF, and I have kids that are 9 and are just now losing ENF. So there's a big range, and that's another reason that those anterior PAs or anterior x-rays are needed. In addition, you really can't do great active surveillance if parents aren't willing to be involved in the process and really help with home care and good diet. And so if you have those parents that are not going to change home care habits, I don't think that this is a great idea for them, or it is not kind of the option that we should give as frequently. In addition, there's sometimes that parents just don't love the look of how those kind of darker carious lesions look, and they really want something to be done about them. And then you're really going to have to be able to assess patient behavior. As we know, those anterior injections are not always as easy to be painless as the posteriors. And try as we might not get great behavior with those. So that has to be part of the treatment plan as well. For composite strip crowns, so these are strip forms that you can purchase. They're that are made of plastic that look like anterior teeth. And what you can do is you can prep the teeth like you would for a pre-veneered stainless steel crown. But instead you fill it with filling material, with resin material, and cut the plastic form off. It a lot of times can give you a really beautiful result. What I typically do with these forms, and I personally use NOAC strip crown forms, but there's lots of options out there for different strip crown forms. You have to find which one works the best for you. And what I do is I look at a strip crown form, compare it before I start working on the tooth to the incisal edge of the tooth I want to replace it with. And that is the size that I'm going to use eventually. These are not reusable. So if you've trimmed one and you've tried it on, this has to be thrown away afterwards. You're not going to be able to sterilize this, obviously. what I will typically do is use a flame diamond to reduce in all areas. So incisal, interproximal, facial, and lingual surfaces by 1 millimeter. So one of the benefits of using composite strip crowns over the stainless steel or the zirconia crowns is that the preparation is requires much less loss of tooth structure than the other types of crowns. So only 1 millimeter do I have to reduce, whereas I have to reduce quite a bit more than that for zirconia crowns. Then I am going to make sure that all of the decay is removed, trim the crown form, and then I do use an explorer to place a vent hole in the lingual for venting of the composite. If you don't, and you push the strip crown on while it's filled, it'll be filled about half full with composite. As that composite extrudes out the lingual and the buccal, it will actually tear the strip crown form typically, and then you kind of have, I mean, you can usually fix it, but it just takes a lot more time. And so if you have that vent hole, you can progressively take away that excess composite over time. I do like to place bonding agent on the intaglio surface of the crown form. This makes the removal of the crown form easier. I then etch and bond the teeth that I am restoring. Your assistant will fill the crown form about half full with packable composite, and then you seat the filled crown form while getting rid of the excess composite with your instrument, whatever instrument you're using. I use the plastic instrument, but you could use whatever composite instrument you like. And then you're going to light cure. The way that I remove the crown forms is I will cut a linear opening in the lingual of the crown form and then use a spoon to remove it. Of course, use your throat pack. Other people can find that they have luck with just using a plastic instrument or a spoon subgingivally and kind of pulling the crown form off. So, kind of experiment with what works best for you. I find that doing the lingual cut on the lingual surface of the crown form is faster for me, but it does increase my time that I have to spend on smoothing that lingual surface. So up to you. And then you will finish and polish. And you can see here that you can get a really nice look of those composite strip crowns. Kind of downsides of them sometimes are that they will fracture a little bit easier. So if I have any zirconia crowns, I'm not going to be using a composite strip crown either adjacent or opposing because you will find that they fracture a little easier. They do stain easier. So you will, over time, you can see, especially kids that have gotten strip crowns at 2 years of age, will come back with some brown staining on these composite strip crowns. So just something to warn parents about. And sometimes because they're not as subgingival of a prep and you're using resin material, they are more susceptible to recurrent decay. These are the pre-veneered stainless steel crowns that I use. I use the New Smile Signature. They look pretty natural. There's two different colors. There's a light and an extra light. I tend to use the light because the extra light looks very, very white. I personally like the way that these look better when you are crowning all 4 or all 6 of the primary anteriors, maxillary anteriors, just because they don't have as natural of a shape as the zirconia do, and also not as natural of a sheen as the zirconia do. So they don't look as natural directly next to a natural tooth. I also do not place these when I have an opposing tooth that is zirconia, because that pressure or those occlusal forces will cause the pre-veneered portion to fracture off. And so I see this a lot with canines, with like excursive movements with primary canines. Kids will pop the veneered portion of the stainless steel crown off, and parents will frequently come in thinking that the child has lost the crown altogether, when that's not actually true. They've just lost the resin facing of the New Smile. So that's one of the downsides of the New Smiles, but they do have less recurrent decay than composite strip crowns. They fracture less frequently than composite strip crowns, and they don't stain. So the technique is, again, you'll size the crown based on preoperative tooth size. So you're looking for that incisal edge size. I use a barrel diamond for facial, lingual, and incisal reduction. I do a 2-plane reduction on the facial so that I can make sure that when I seat it, that it's not too flared, buccally. And then I use my flame diamond for interproximal and subgingival reduction, about 1 millimeter. For these, you do not want that snap fit like you did with the posterior stainless steel crowns. You want this to slide on. You want it to be a very passive fit. If you, and this becomes even more important with the zirconia, but if you're really pushing these crowns on, you can definitely fracture them. And then, of course, remove your remaining decay. You'll dry them and you'll cement with a glass ionomer cement. With this particular type of crown, I like using hand mixed key tack because you can mix it a little thicker and then the crowns will stay on better. If you use an auto mix or like Fuji One, that texture is such that you would really have to hold those crowns on for 3 to 5 minutes with your fingers to really make sure that they stay seated where you want them. And so I tend to use that thicker mix of key tack. Zirconia crowns are a really beautiful option as well. They're relatively newer type restoration for pediatric dentistry. We use the New Smile zirconia, but there's several options out there. They do have a more natural sheen, I think. Sometimes if you've got kiddos that have like modeling appearance of their anteriors, this can look too perfect, if that makes sense. And then the New Smile, the pre-veneered stainless steel crowns or the composite strip crowns might be a better option for you. But this is typically what I will use anytime a child has any attrition. So if they have attrition, I know that they're going to fracture the facings off of my pre-veneered stainless steel crowns. And so I will take a picture of the teeth that have defined attrition so that I can submit that to insurance as a narrative of why I've had to use these zirconia crowns. Zirconia crowns are more expensive, of course, and so sometimes insurance likes to fight us a little bit on covering them, but that is one of the indications for them is attrition. In addition, they have a little bit more natural of a coloring, I believe, than the traditional pre-veneered stainless steel crowns. And so if I have a single tooth that needs restoration, this is usually what I'm going for. For lower anteriors, I go for these because I can't use the pre-veneered because they will fracture. And so if I have to do any lower anteriors, I'm automatically doing upper zirconias as well to help with that occlusal force. You can see that these can look very nice. So this was from the Easy Pedo website, now Sprig, regarding, just a post-op view of what their anterior zirconias are like. So they did resin restorations, direct resin restorations on C and H, but D through G are their zirconia crowns. I did make a video of me doing some anterior full coverage restorations, so I'll show that to you real quick. Again, I'm going to turn the sound off so you don't have to listen to the dry shield, or actually this might be rubber dam because it was a while ago, and you don't have to listen to the handpiece. Okay, so again, a kiddo under general anesthesia, and my camera person is going to move here soon so you can see better. I usually start with a barrel burr with my incisal reduction. I want 1 to 2 millimeters of incisal reduction. I'm really making sure that I kind of keep these even or anatomical so that I don't have one that seats more subgingival than another, and then it doesn't look like the incisal edges match up anymore. So that's one thing that you have to make sure that you're doing. Here I'm doing both facial and lingual reduction. If I were redoing this video now, I would do more facial and lingual reduction than I'm doing right here. And so that's one thing is don't be, know that you're going to have to take some tooth structure off to really get a good fit of these, especially that passive fit that you want. Again, I switched to a barrel or I'm sorry, a green flame diamond for my interproximal. I am going subgingival here, especially at the cingulum. You're going to want to take quite a bit of the cingulum off. I'm also currently rounding the edges because if you have a sharp edge, you're more likely to fracture that crown. So rounding of the edges is really necessary. Getting that subgingival margin is really necessary. And again, in a situation where we want to be efficient, where I would suggest using your barrel burr in entirety first, and then switching over to your interproximal burr so that you can just spend as little time as possible switching burrs. And for the anteriors, you really are going all around the buccal and lingual, unlike stainless steel crowns for the posterior, where you're not really utilizing your interproximal burr or your flame diamond on the buccal and lingual. This is going to be necessary in order to get that really gliding fit, passive fit of your anterior restorations. And again, as you do more and more of these, your assistant will be able to kind of pick out those crowns for you. Here, what I'm finding is, and I can even tell it from this angle, I've got a little bit of resistance on the mesial line angle of that crown. And so I'm going to go back and repeat a little bit of interproximal reduction. Number G isn't fitting on all the way, and I can tell it's on the lingual. And so that just takes a little bit of practice, kind of being able to feel where you've got that resistance and making sure that it is a passive fit. And so you see, I struggle, there's a little tension there that I struggled to get those off. And so I'm not going to have you watch more of this reduction, but basically I just go back in and reduce some more. It is surprising to me sometimes how little you have to go back in and do additional reduction before you can get a crown that didn't seem like it was going to seat to where it is that passive fit at the end. Okay. And now we are to the point of talking about pulpal treatment of primary teeth. And we're going to split it into vital pulp therapy versus non-vital pulp therapy. But I just want to stop and see if there's any additional questions that I need to answer.
I do not see any in the chat.
Okay, perfect. Well, pulpal treatment of primary teeth, I think all of us have pretty good experience with doing pulpotomies in dental school, at least from the students that I am getting right now at Jordan Valley from UMKC and Mosdo. It seems like at least you've had the opportunity to really talk about pulpotomies from doing them on typodonts, if not having several experiences on your rotations. However, there are other options out there. So we are going to talk about indirect pulp therapy as well as pulpectomies, something called LSTR or lesion sterilization and tissue repair. And then of course, extraction is our last option for a non-vital primary tooth. So indirect pulp therapy is actually, from an evidence-based perspective, typically more successful than pulpotomies. Most pulpotomies, the success range is around 89%, and an indirect pulp cap, when it is warranted and when it has a good patient selection or good tooth selection, is in the mid 90s as far as being a successful restoration long term. That being said, and this is from an article, I probably would not have gone with an indirect pulp cap with a specific tooth, but they did, and it worked out for them long term. However, in this case, this would have been a pulpotomy all day long for me. But there are some, if you can look at an x-ray and clearly see a band of dentin, secondary dentin that has formed where you do not need to do a pulpotomy, you would be great to go ahead and do that indirect pulp cap. This is reserved for vital pulp, so you want no mobility, no periapical pathology, and definitely no spontaneous pain. And sometimes it's difficult to tell with kids because they'll say things like it hurts all the time. And when you really have to be able to assess the parent's ability to give you history, because a lot of times what that means is they ate candy and then it hurt for a while after they ate that candy, or that it hurt while they were they got food stuck in it or something like that, that isn't true spontaneous pain. From an evidence-based perspective, it is also best to cover these with a full coverage restoration, get less leakage, get less possibility of the pulp becoming inflamed. From a technique perspective, you're going to remove undermined enamel with a high speed. Use a large round burr at slow speed to remove the infected dentin and clean all of the peripheral walls. And you can leave carious dentin to the central region over the pulp. So you want to be within about 0.5 millimeters of the pulp. Usually we'll use a glass ionomer base with margins in sound dentin, and then you can do your restore or your definitive restoration. For a pulpotomy, there's lots of agents out there, and I think everybody has kind of their favorite. I was trained on both ferric sulfate and formicresol. They both have their benefits and detractors. I would say that parents nowadays, as they talk about agents that they're comfortable with, they're less comfortable with formicresol. Ferric sulfate is known to have more incidences of internal resorption. And although that doesn't necessarily mean that you are going to have to extract the tooth, at times it becomes so severe that you do have to extract the tooth. One of the agents that was kind of in the running for kind of gold standard along with formicresol back when I graduated from residency was MTA. I think at this point it has become the agent that is most liked and most successful in the literature. It's what I'm currently using, and I've had really good luck with it. There are some MTA agents out there that are less expensive than the traditional kinds that you might be used to. We use Neo MTA, which is made by New Smile, but there's other options out there. I just know that that one has been a little bit less expensive than some of the traditional MTAs. Another good track record item is sodium hypochlorite. I will use that in my pulpectomies typically, not as much my pulpotomies, but that is an option out there for you. Calcium hydroxide and laser are other options that have been investigated, but they're less predictable. I said probably not to direct pulp cap for carious exposures. However, the AAPD in some of their more recent publications has started to allow for direct pulp caps with primary teeth, but in very minimal quantities. It has to be pretty minimal of a carious exposure. Technique for a pulpotomy is I would suggest that you always prep for your crown first. You're going to get to the point where you have a lot of that tooth structure gone that you need to be gone for your pulpotomy just by prepping for the crown. And then you will take out the decay and the pulpal floor removal with your high-speed handpiece. I usually use a 330 burr, but a 245 could be an option as well. I would recommend that you completely unroof the chamber with a slow speed and round burr, because if you continue to use your high speed, you risk going into the furcation and rendering the tooth unrestorable. And so utilizing that slow speed and round burr at that point will help you get to the point where you've removed the entire roof and you have removed all of the coronal tissue without ending up in the furcation. One of the tricks that I tell students when they're working with me to do is to utilize that slow speed until the consistency. So initially you'll get into the pulp and it'll be very kind of liquidy or watery heme that you have. But if you go to the point where you've removed all of the coronal pulp tissue, you will get a consistency that is kind of crumbly. And that is because you're starting to get dentin mixed in with the pulp tissue. And so once you've got that crumbly mix, you can take a look, make sure that you have all of your pulp canals opened, and then use your cotton pellet pressure for any more hemostasis than you need. Often, if you've done enough slow speed removal, you will already have hemostasis and can skip the cotton pellet pressure. But if you're still having bleeding, you'll want to use just plain cotton pellets for hemostasis. If you start using formicresol or ferric sulfate at that point, you may artificially be having the hemostasis occur from a chemical reaction instead of actually being to the point where the coronal pulp tissue has been removed. After that, you can use your formicresol, your ferric sulfate, your sodium hypochlorite, or your MTA. I place MTA at that point with an amalgam carrier and then put my IRM right on top of that. IRM should go in the chamber after your medicament to help support the tooth after or once you've placed the stainless steel crown on it. I like the IRM to feel almost like a piece of chewed up bubble gum, and then place it in the chamber. You'll want to use a Q-tip or a cotton tip applicator to really push that IRM into the chamber so that it really gets down into the pulp orifices, so that you can have that good, well-fitting, well-sealed restoration. And then, of course, remove your excess IRM because that stuff really gets very hard and can cause a perio abscess if you leave it in the interproximal region. Preferably, then, you'd place your stainless steel crown over that. Pulpectomies are an option for non-vital pulp therapy. So these are for teeth that have had symptoms or that are starting to have some changes in the radiograph, but that you really want to keep them for strategic purposes. Maybe it's for space maintenance, a primary second molar that you need to keep because you've lost a primary first molar. And if you lose the second, you're not going to be able to do any space maintenance, or maybe for aesthetic reasons. So a lot of parents will want to keep anterior teeth that the caries are directly into the pulp and are starting to have symptoms, and then we'll do pulpectomies on them. Most people agree, or most people in pediatric dentistry agree not to do these as much on primary first molars. Number one, because they can easily be replaced with a band and loop space maintainer. Of course, the best space maintainer is the natural tooth. But the other reason why we don't do these as often on primary first molars is because those canals are very thin and the dentin walls are also very thin. Those roots are very spindly. And so there's not as much room to really be able to get some Vitapex in there and do a really good job on those pulpectomies. They can be done though. Technique wise, again, I would prepare for the crown first, and then remove your decay and unroof your chamber. Then you will use a broach until you reach resistance. So this isn't a root canal. You're not going to be trying to find length. You're going to till you feel resistance in all of the pulp canals. And a lot of times, if you are utilizing the broach pretty effectively, you can get the entirety of the pulp to come out with the broach. But if you don't, you will hand file to preference. Now, for posteriors, I typically use K-files 10, 20, and 30. And for anteriors, I'll use 30, 40, 50, and 60, just depending on how wide that canal is. Once you've hand filed, again, you're going to file to resistance again. You're not going to be looking for a specific length. You'll then irrigate with sodium hypochlorite and dry with your paper points, and then you'll fill with Vitapex. And Vitapex is a relatively radiopaque material. The other thing is that it easily resorbs, which is important because these teeth need to be resorbed in order to exfoliate and allow the permanent teeth to erupt properly. So if you see that you've got some extrusion of the Vitapex beyond the apex once you are doing your pulpectomy, that is okay. You do not need to extract the tooth. You don't, I would maybe tell the parents that it's there, but it is not going to cause problems for the permanent tooth from an evidence-based perspective. I would also recommend that you always take a post-fill radiograph. Number one, that can show you if there is some extrusion or if you have gotten a good fill, if you've filled all of your canals, of course. But the other reason is that that Vitapex sometimes washes out of your respirations, and this proves to the insurance company or to anyone who might be auditing you, to lawyers, whatever the case may be, that you actually performed the pulpectomy when you bill it out. Because sometimes you will see that kids will come back who have had pulpectomies on their anteriors, and there's no Vitapex in the chamber when they come back for postoperative radiographs a year later. And so this kind of shows, yes, I did this treatment. It saved the tooth long term, even though it washed out in the end. Lesion sterilization and tissue repair is an alternative to pulpectomy and extraction, and it is also for non-vital primary teeth. So these are teeth with symptoms. These are teeth with radiographic changes. Of course, the best space maintainer is a natural tooth, like we talked about. They are very technique sensitive, but they have about an 85% acceptable outcome percentage. And the way that you perform LSTR is by utilizing a triple antibiotic paste. Typically, that's metronidazole, ciprofloxacin, and minocycline, but we personally have it compounded at a compounding pharmacy and use clindamycin in place of minocycline due to the possibility of it staining and discoloring the tooth and gums, the permanent tooth and gums for patients 12 and under. That being said, the original LSTR article, they did not replace it. They just kept the minocycline, and there haven't, that I know of, been any case studies of undesirable outcomes. They also add iodoform to the product so that it can be radio opaque and you can see it in the radiographs. In the state of Missouri, it has to be prescribed for a specific patient. So what that means for us is if we have a kiddo coming in pain that day, I'm not going to be able to do lesion sterilization and tissue repair that day because I am going to have to order that material for them. So that sometimes limits the ability of us to utilize this particular treatment plan. This also can be useful in permanent teeth, and so some endodontists will utilize this in like revascularization or other types of procedures. So procedure-wise, you will take a preoperative radiograph and get your anesthetic completed, and of course isolate the tooth. Usually with a rubber dam would be better, but at least a good isolation technique will be necessary. You'll get your pulpal access just like you would for a pulpotomy. But instead of finishing with just your slow speed, you're also going to enlarge your canal orifices by 1 millimeter in diameter and 2 millimeters in depth to create something called a medication cavity. And that's where your LSTR material, your triple antibiotic paste, is going to go. Another difference with pulpotomies is that with the LSTR, you are going to etch the tooth and then rinse and dry. You can control or get hemostasis with sodium hypochlorite if you need at that point, but then you will place your triple mix on or in the medication receptacles and all over the pulpal floor. Then you seal with a glass ionomer and restore with a stainless steel crown. And so this, like I said, this is an alternative to a pulpectomy procedure. So this is a kiddo that number K had a deep amalgam restoration, and it looks like it had probably hit that mesial pulp horn and had caused an abscess. This is our 3-month follow-up. We continued following this tooth, and it exfoliated naturally with no undesired outcomes to the permanent premolar. So it allowed that tooth to be kept long-term until the permanent tooth came in. Okay. We're about to move on to our last section, which is regarding pediatric oral surgery, including frenectomies. I do think that there's a couple of things in the chat.
Correct. First, we want to clarify that your preferred MTA is the Neo MTA.
So I personally use Neo MTA, but that's only because I don't have any like association with New Smile or anything like that. I just utilized that because it was a material that came out at a time when MTA was very expensive, and the Neo MTA allowed you to measure and mix your MTA. I am sure that there's other companies out there that make a similar product now that is not as expensive as the traditional MTA that has been out for many years that was super expensive. But that is the one that I use. It's just an example though.
Okay. What's not expensive out there? That's right. I mean, everything's
Right,
expensive these
exactly.
days. All right. Well, when you were doing one of your procedures videos, the question was asked, are you using approximately a number 6 RD slow speed burr to remove the coronal pulp tissue?
Yes. So I do want kind of a larger round burr. I don't want those size 2 round burrs because what it does is it tends to burrow down into those pulp chambers or those pulp canals. I do want kind of a larger size. I would say 6 would be about my average for that, so that I can fit inside my access, but then also like use it pretty efficiently to get that more crumbly texture and get past the coronal pulp tissue.
Okay, great. That clears the chat. You can move on.
Okay. So we're going to talk a little bit about pediatric oral surgery, mostly when to extract things like supernumeraries, when to plan on extraction of primary canines, and frenectomies. So we are also going to talk about considerations that are specific to the pediatric population, including things like prescribing antibiotics. And we'll also talk a little bit about natal and neonatal teeth. So with pediatric oral surgery, and especially if you are performing complete oral rehabilitation under general anesthesia or working with an oral surgeon to do kind of deep sedations, just know that dehydration and hydration status is of heightened concern in the pediatric patient. So pediatric patients are much more likely to become dehydrated than an adult patient. And so if you are performing those procedures, kind of knowing how long that they have been NPO and then being able to get them back to proper hydration status is going to be really important the day of the surgery. In addition, the pediatric airway is much different than an adult airway, and respiratory compromise happens much more easily in the pediatric patient. So you really need to be wary of swelling. You need to be really cautious with kids that have been ill, especially with respiratory illnesses, because their ability to really move air is much different and much lower than that of an adult. Of course, antibiotic use should be judicious and based on AAE guidelines. Right now, the AAE and the ADA are not exactly completely in tune with each other on their use of antibiotics. I tend to go with the ADA just because I have access to general anesthesia a little bit more. And so I do have times where I need to kind of delay definitive treatment because of behavior until I can get a kiddo into the OR. And so sometimes I am utilizing antibiotics to buy that time for myself. For children, Pen VK is still the treatment of choice. For Pen VK, you want to do 25 to 50 milligrams per kilogram divided in 3 doses every 24 hours for 7 days. The suspension, so most kids are obviously going to want liquid formulas and not a pill form. Those suspensions come in 125 milligrams or 250 milligrams per 5 cc concentrations. And so I really work backwards to determine how I'm going to prescribe my antibiotics for my children. So for example, if I have a 16-kilogram child, if I went with the maximum dose of 50 milligrams per kilogram, that would come out to 800 milligrams per day, which is going to end up being like kind of a more difficult amount for the parent to measure out if you divide it by 3 doses. So if I make it 5 if I have them take 5 milligrams every 8 hours, it will make it exactly 47 milligrams per kilogram per day. And then all they have to do is do 1 teaspoon. They don't have to measure out any silly amounts. And so obviously all sorts of children are going to be all different types of weights. And so I'll just work backwards. If I want to really make sure that my parents only need to measure out 5 milliliters, then I'm going to work backwards from the 750 or the 375 mark, to be able to allow that for them and to make it easier on them. Patient compliance is going to be a lot better if they don't have to measure 3.6 milliliters every 8 hours. It'll be a lot better if they can just do a straight 5 milliliters or even 4 milliliters. For extraction of erupted primary teeth, anteriors, I only use rotational force. Posteriors, we use buccal and lingual force. Fractured roots with those posteriors are common just because those roots are thin and spindly. If you do have a fractured root, the technique that you would then use would be first take a PA radiograph to note the relationship to the developing tooth bud. Make sure you're supporting the mandible. And just because there's a primary root tip that is retained doesn't mean it needs to come out. So what you're going to have to consider is damage or accidental extraction of a developing tooth bud. The AAPD guidelines state you can try several times to get those root tips out, but if you can't get them after several good tries, you leave them in order to minimize damage to the permanent tooth bud. Another thing I've noticed as I've been working with students from AT Still and UMKC is that a lot of them have said that they have been told not to use an elevator on primary teeth due to possible damage to permanent tooth buds. I have not been able to find any literature regarding that. And what I can tell you is that you do have a really good chance of damaging a permanent tooth bud if you fracture the primary tooth and then need to kind of go digging for it. So my recommendation would be to always, especially with posteriors, use an elevator before you start using forceps to remove primary posterior teeth. For unerupted and impacted teeth, so one type of unerupted tooth that we can see is either primary or secondary failure of eruption. This just means that a tooth did not come in. It should have come in, but did not come in for whatever reason. This could be due to a syndrome, or it could be non-syndromic. And really what the AAPD guidelines state is orthodontic movement a viable option? And if it's not, then their option is to extract. Another kind of developing treatment option is for an oral surgeon to do selective elevation. So lay a flap, do selective elevation of that specific tooth to see if you can stimulate the tooth to have some more eruptive force. Sometimes it will work and sometimes it will not, but that at least gives it a chance if parents are motivated to not want to extract that tooth. And then for impacted canines, so you do want to both palpate and take a radiographic evaluation of developing canines, at least by age 10. And so what you're looking for is feeling in that buccal vestibule. Can you feel the buccal bulge for the permanent canines? If you can't, you really need some radiographs to be able to determine where those are. So I've gotten this second radiograph here, an example of canines that are really mesialized. And so the rule is, if the cusp of the permanent canine is overlying more than half of the long axis of the root of the permanent lateral incisor, then impaction is likely. So what the rule of thumb is around the time that the permanent canine root has 2/3 development is when you want to extract the primary canines in hopes that tooth will erupt on its own. And that is successful if you do it at the right timing, about 67% of the time. It can be even more successful if the tooth is less mesialized than these. So extraction of primary canines when the permanent canine has 2/3 root development and the cusp tip is mesialized is an important consideration and one of the reasons that you should be taking timely panoramic radiographs. Supernumerary teeth kind of go by that same rule. We want to remove supernumerary teeth, impacted supernumerary teeth, when the adjacent permanent tooth has about 2/3 root development. And that's so that when you go in there to remove that supernumerary, that you have less of a chance of damaging that permanent tooth bud. About 33% of all primary supernumeraries are followed by a supernumerary in the permanent dentition, and these are 10 times more likely in the maxillary arch. So you should really be suspicious of a mesiodens or a supernumerary in the maxillary if there's asymmetric eruption of the maxillary incisors. And so if I've got number 8 that comes in and then I see them at their next recall and number 9 is still not in, I'm taking a radiograph again to make sure that I don't have something going on that I need to address. It could also cause complete delayed eruption of the maxillary incisors or even ectopic eruption of a maxillary incisor. So let's say number 8 comes in line with the arch, but number 9 comes in super buccally. I'm going to be looking for additional teeth or pathology that would cause that. So potential complications of impacted supernumerary teeth include delayed and or lack of eruption of the permanent tooth, crowding, resorption of adjacent teeth. It can turn into a dentigerous cyst. It can also cause pericoronal space ossification and crown resorption. And so, I used to work in an ortho office, and a lot of times we would see this if the referring dentist didn't catch this in time because they hadn't been taking panos or hadn't been taking PAs of the anteriors, or if the kid just hadn't been going to the dentist at all, we would see permanent teeth that ended up being lost due to these supernumerary teeth that were not removed in a timely basis. Again, extraction of a permanent unerupted mesiodens is recommended when adjacent incisors have at least 2/3 root development in order to present less risk to the developing teeth. And then the adjacent teeth should erupt within 6 to 12 months. If not, surgical exposure and orthodontic extrusion might be necessary. For natal and neonatal teeth, just remember natal tooth is present at birth, whereas neonatal teeth are present within 30 days of birth. It's typically the normal tooth in the primary dentition. So, when you see these teeth, they're likely either number O or P or both. And so if you remove those teeth, they're not going to have that tooth later when they're an older child. It can cause riga fidi, which is a lesion caused by breastfeeding in the presence of an anterior natal or neonatal tooth. The treatment there, so that is where the tongue gets a really kind of sore lesion on it from the roughness of that tooth. The treatment recommended by the AAPD is smoothing that lesion. Easier said than done on a wiggly newborn, but that is a possibility. The AAPD recommends extracting only if the tooth is excessively mobile. And what that means is it an aspiration risk? So keep in mind, these babies are not going to have much mandibular bone. And so all of these natal and neonatal teeth are going to feel mobile. What you're really looking for is it likely that this tooth is going to completely avulse and become an aspiration risk to this infant? And so really it's pretty rare for a natal or neonatal tooth to be need to be removed. Phrenotomy and frenectomy in children. This is a pretty controversial subject. Recently, the New York Times published a pretty big expose on what they called the booming business of cutting children's tongues. And I have some beef with that particular article, but I will say it comes from probably a good background in that it is probably likely that there's dentists out there that are cutting tongues and lips that don't need to be cut. And what we have to remember is that everybody has a frenum. Everybody has buccal frenum. Everybody has a labial frenum, or should have. Everybody has a lingual frenum. It's just what really matters is the mobility of those tissues and whether there's any symptoms. So indication wise, you really should be looking for symptoms of needing treatment. So in an infant, I'm looking for feeding issues. If I have a baby come in and yes, they have a tongue tie that, it looks like and I'll show you the Cotlow designation in just a moment. But it looks like they've got kind of a tight tongue, but they are gaining weight and they're able to babble and they're not having any feeding concerns at all. It's not necessary to do a frenectomy at that point. In young children, I'm now concerned about speech or dental concerns, but I'm also concerned about their ability to tolerate treatment in the dental office. So we need to consider that as well. One thing that disappoints parents is that not all speech concerns are caused by a tongue tie. So if you've got a kiddo who's not picking up words quickly enough, that's not the same thing as not being able to move your tongue well enough to say certain sounds. And so you're really looking for like errors in the L sound, the TH sound, the D sound, any of those sounds that are made by lifting the tongue up to the hard palate or to the teeth, or sticking the tongue out that they don't have mobility for, those might be indications for a frenectomy in a young child. Another difference between infants and young children is whether anesthetic is needed. Typically, very young infants, so newborns that come in, do not need full anesthetic, full infiltration. Instead, we're using pressure and then soothing with breastfeeding afterwards. They don't have full innervation of that tissue, and it's usually very, very thin. In young children, usually I will infiltrate with lidocaine. Now, I don't bilaterally block for these, although bilateral blocking is something that the AAPD believes is, or from an evidence-based perspective, does not actually increase the chance of lip biting. I don't think that it's necessary. You only need that anesthetic for a very short period of time, and you just need soft tissue anesthetic or anesthesia, so infiltration is sufficient there. These are the Cotlow designations of different tongue ties and lip ties. I just utilize this information for narratives for my insurance purpose. Again, I am not deciding whether to perform a frenectomy based on looks, though. I am utilizing this as kind of a diagnosis tool, but really getting into the history and understanding what the symptoms is really where we're going to decide if we need a frenectomy or not. So the differences, frenotomy is clipping of the fibrotic tissue. It may or may not require anesthetic. Generally, you will use surgical scissors, and it's usually used on infants or very young children. There is a high chance of recurrence, and it's very conservative. A frenectomy is when you have total excision of the frenulum and you get a diamond-shaped wound. And so I have kind of a picture on this lower here. This was a kiddo under general anesthesia that had like a Cotlow 3 tongue tie, but he was having some speech issues that were definitely related to lifting of that tongue. And you can see exactly that diamond-shaped wound here on the lower picture post-operatively. Generally, you need anesthetic for that. So even under general anesthesia, we did use a little anesthetic that also helped with bleeding control. And you can use scalpel, laser, or electrocautery, or surgical scissors. You may need a suture. In this case, I did not remove enough tissue that I felt I needed to suture, but some people do suture after every visit. I know a lot of ENTs will suture for every visit. Now, you do want to prevent this tissue from readhering to the floor of the mouth or readhering tighter than it was previously. And so tongue exercises are required afterwards. And I usually recommend about 3 times a day for 2 weeks that kids do these tongue exercises. They can stick out their tongue as far as they can, try to touch their nose, try to touch their chin. Another thing that they can do is put peanut butter in a shallow cup and try to lick the peanut butter out of the cup. And that will allow them to stretch that tongue and really keep that or have that wound heal by secondary intention, which is actually what we want here. I did put a little bit in here about space maintenance. For everybody who is watching kind of after this, this is a chart of when a space maintainer is indicated and when it is not, and what types. So primary first molars, you only need a space maintainer when the permanent first molar is not in occlusion yet, and then you'll use a unilateral fixed band and loop space maintainer. For maxillary primary second molars, you will use, and mandibular primary second molars, you will generally use a distal shoe before the permanent molars erupt, and you always will need a space maintainer when you have early loss of a second molar. You can switch those out for a Nance or a lower lingual holding arch once you have some permanent teeth erupted. So for a Nance, you just need the eruption of number 3 and 14 to put your bands on. For a lower lingual holding arch, you need number 19, 30, and 23 through 26 so that you can avoid impacting the permanent anterior teeth. For mandibular primary canines, you also will need a lower lingual holding arch. And you do not need any space maintenance for early loss of primary centrals or laterals, as long as the maxillary primary canine has erupted. I showed you here what a distal shoe should look like, and you should, just like with a pulpectomy, be taking a pre-cementation film to make sure that you have this blade in the right place. This is a prefabricated distal shoe, so not one that we took an impression for. It just has a loop or a band that goes around the stainless steel crown on number L here, arms that face backwards, and a blade that fits into the arms in a trombone fashion. You do have to crimp these arms in order to make sure that the blade does not move, and then we take an x-ray to make sure it's placed correctly. I always do use a Howe plier to get this curve of the blade. The blades come prefabricated as straight, but of course the mesial surface of your permanent first molar is curved. For band and loops, you want that loop to fit right below the height of contour of your canine. You're not wanting to use band and loops for long span space maintenance because it will push the loop into the gingiva, and the gingiva will overgrow the space maintainer, which will be very painful to remove. So this should be only indicated with the loss of one tooth. These are our Nances and our lower lingual holding arches. You can see that the wire for the lower lingual holding arch fits just on the lingual of number 23 through 26. If you've seated this before the eruption of 23 through 26, because those teeth form lingual to number N through Q, you could run the chance of causing ectopic eruption of those permanent anteriors. The palatal button for the Nances should fit posterior to the incisive papilla, and it should be smooth and well-fitting so that you don't get irritation under that palatal button. Okay, and that was the end of the oral surgery section and the end of the part 2 presentation. Are there